Hello, my name is Joy Koenig. I am a labor and delivery postpartum nurse at a university hospital, and I decided to do my presentation on preeclampsia. A little bit of background on the patient in this scenario is that she's a 40-year-old. She's a G3P2, which that means this is her third pregnancy, and she has 2 living children. Currently, she has 35 weeks and 6 days gestation, and she came into the obstetrics emergency department for a headache and blurred vision. A little bit more background. Her last ultrasound was performed at 34 weeks to confirm gestation, and she is advanced maternal age, so they want to make sure that baby is developing properly. She did miss her 35-week appointment, so she's not been seen by the doctor for a little under 2 weeks. At home, she takes a blood pressure medication, Procardia, and she does take aspirin. Her previous pregnancies were induced at 37 weeks and 38 weeks for blood pressure issues. When she was brought into the emergency room, she had her labs drawn, and they are as followed. Hemoglobin is 14.1, white blood cell count 11,850, and then she did have some elevated liver enzymes. They ended up doing a straight cath and got a protein creatinine ratio of 0.3. Her initial assessment vital signs were elevated. Her blood pressure is 160 over 102, which this is categorized as severe blood pressure as it is above or equal to 160 systolic and above or equal to 90 diastolic. She did have an elevated heart rate, but all of her other vitals are within normal limits. Per policy, she had her blood pressure taken again in 15 minutes, and it was 162 over 98. This is a sustained severe blood pressure, and there needs to be interventions by the provider. Once consulting the provider, it was recommended that the patient be induced for labor and that magnesium sulfate is initiated due to the preeclampsia. In order for a patient to be diagnosed with preeclampsia, they have to have some of the following things: a systolic blood pressure of greater than or equal to 140 or a diastolic blood pressure of 90 on 2 separate occasions that are taken at least 4 hours apart, or they can have a systolic blood pressure of 160 or a diastolic of greater than or equal to 110 on 1 occasion. At the hospital that I work at, we have to have a 15-minute recheck of blood pressure if it is a severe range blood pressure. If it is continually be severe after the 15-minute recheck, it is then sustained, and we need to have interventions by the provider. One of the following things must also be included: a protein creatinine ratio of greater than or equal to 0.3 milligrams per deciliter, elevated ALT or AST levels, those are liver enzyme levels. If the patient has a new onset headache that is not alleviated by pain medication, or the patient's having visual disturbances, spots in their vision, blurred vision, changes in how they're seeing, if they're seeing flashing lights, all of those things would be incorporated in the visual disturbances. Now that the patient has been initiated a magnesium sulfate, we usually do a 4-gram bolus. It could also be a 6-gram bolus, but this patient has a low enough BMI that a 4-gram bolus is what is required. This can also be called a loading dose. The loading dose will take about 30 minutes to administer, and during that time we take blood pressures every 15 minutes. And then once that 30 minutes is up, we go to a 2-gram maintenance bolus, and from there we do blood pressures for every 30 minutes. We do that twice, and then we'll go to hourly. If the patient ever has a severe blood pressure, then we would need to move that frequency up to either 30 minutes or every 15 minutes until they're cleared by the doctor. The magnesium sulfate infusion will go for 24 hours after delivery. This patient is still pregnant, so this will run while she's laboring, and then it'll take 24 hours after she delivered to stop the infusion. We have to call and get an order to stop that infusion, but usually there's standing order to call at 24 hours. The patient will also be put on an antihypertensive medication Currently, she is on 30 milligrams of Procardia daily. The doctor is going to increase that to BID Procardia 30 milligrams. At the hospital that I work at, we also have a standing order of 20 milligrams of labetalol as a rescue dose to help bring a severe blood pressure down into an acceptable range. My 2 clinical reasoning questions are, what are the things that need to be monitored for when the patient is on a magnesium sulfate infusion? And what are the signs of magnesium toxicity? And if a patient shows these signs, what should the nurse do? Both of these are very important as we do hourly mag checks, which is checking reflexes, if they're having visual disturbances, or if they're having any pain in the upper quadrants, or if they're having any numbness, tingling in their fingers or their toes. These are my references. Thank you so much.